Vyas will present first, and then we'll try and connect with Dr. Barun Nayak again. I would like to take this honor of introducing Dr. Prateep Vyas. He is a fellow from the L.V. Prasad Eye Institute, Hyderabad, and he's an expert in glaucoma, anterior segment phacoemulsification, and oculoplasty. He is the medical director for Center for Sight at Indore. He was the vice chairman of the amazing conference that we had at Indore. That was the 77th All India Ophthalmological Society.
ज्वाइन तो लगता हो गया, लेकिन
ex-honorary General Secretary of the Glaucoma Society of India. He has been the past president of Indore Divisional Ophthalmological Society. He was the ex-medical director and trustee of Shri Ganpati Netralaya, Jalna. He is a member of the editorial board of the Indian Journal of Ophthalmology and the Asian Journal of Ophthalmology. He has 11 peer-reviewed publications, 9 book chapters. He has received the Rai Bahadur S.H. Shri Pandit Award, Sadguru Award, Marathwada Bhushan Award, the Bombay Ophthalmic Association Gold Medal. He has got several orations, and he has been invited as faculty in the prestigious conferences worldwide. We would like to request Barun sir, आपका हो गया sir? We would like to request Dr. Prateep Vyas to please begin with his presentation. मनीष एक बार वरुण सर से बात कर लो.
डॉक्टर वरुण नायक सर,
फोटो तो उनका देखे थे.
आई थिंक वो स्लाइड डॉक्टर प्रदीप व्यास सर का ही स्क्रीन आया था वो. आई थिंक वी कैन स्टार्ट डॉक्टर प्रदीप व्यास सर.
हाँ. प्रदीप सर, प्लीज शेयर योर स्लाइड्स.
Okay. My slides. There.
We can't see, sir.
We can see a screen. Slide अभी नहीं दिख रहा.
Here's the slide. I'm seeing the slide.
Then sir just wait करिए, आ जाएगा तब सर.
दिख रहा है?
नहीं सर, आया नहीं सर.
नहीं है. एक बार फिर से करिए सर स्क्रीन.
Again I'm sharing.
So go to desktop and then
Yeah.
TV लिखा हुआ. हाँ आ गया
आ गया सर.
इसको स्लाइड स्लाइड शो.
वो नहीं, स्लाइड शो भी नहीं आ रहा. जैसे ठीक है. I have enlarged it. Is it visible properly?
Yes sir, visible sir, visible.
Yeah. So no, yesterday we tried a lot. When I was doing the slide sharing, it was not coming over there. So I think I have to. Yes.
Sure, sir. We can start, sir.
Am I visible?
Yes, sir. Yes, sir.
Yes, sir.
Okay. So thank you, Maneesh. Thank you, Satyajit, for this opportunity. And I don't know how many PG students are there, and they have waited for almost a half an hour without any presentation. So it was a big patience for them. I would be speaking on the management option of coexisting and cataract.
मिस्टर मनीष गुप्ता जी, थोड़ा सा आवाज कट रहा है.
थोड़ा सा नहीं, पूरा कट रहा है. हमको तो सुनाई नहीं दे रहा.
सुनाई नहीं दे रहा है?
हाँ अभी दे रहा है, अभी दे रहा है. सर वीडियो ऑफ कर दीजिए तो शायद बेटर आएगा सर.
हाँ,
वीडियो अगर अपना ऑफ कर देंगे तो कनेक्टिविटी इंप्रूव कर जाएगा सर.
नहीं तो मेरे पास वीडियो नहीं है ना कोई.
नहीं, आपका जो वीडियो है सर, आपका पर्सनल वीडियो को अभी बंद करने से वॉइस और क्लियर हो जाएगा.
अच्छा, मेरा पर्सनल. अच्छा ओके, मैं ऑफ कर देता हूँ उसको.
हाँ, तो कनेक्टिविटी इंप्रूव कर जाएगा. यस सर, ठीक. हाँ सर.
Is it better?
Yes sir, better.
Okay. So now when we have a patient having a both the condition, the cataract and the glaucoma, then what options we have? See, the most commonly performed glaucoma surgery across the globe for a patient having cataract and glaucoma together is just a cataract extraction alone. How and why, that we would be seeing subsequently. But obviously, that might be a surprising factor for you, that the cataract extraction alone can be a glaucoma surgery as well. The another option is that we do the sequential approach, the trabeculectomy followed by cataract extraction. That procedure is reserved for those patients who have a very advanced glaucoma. The second option is the cataract extraction you do first. It's called as a reverse sequential approach as well. You do the cataract surgery first, followed by trabeculectomy. This procedure is being done particularly in those patients where you are not able to assess glaucoma properly, and subsequent to cataract surgery, when you assess glaucoma and you see that the patient has a very advanced glaucoma and the pressure is not under control, then you have to do the trabeculectomy. So that is called reverse sequential approach, and that is done very seldomly, not very often. And second most oftenly combined procedure is a combined surgery, that is the phacotrabeculectomy. And now in the Western world, getting popularity, but in our country, it is very, very rarely done. For the simple reason is that the cost is exponentially high. And number two is that we people are not very familiar for putting the eye stent and so on and so forth. Now, I'm giving you the three examples over here. You look at this field. This patient has a very early superior arcuate scotoma. So this patient would qualify just for cataract surgery alone. And this patient has a significant superior arcuate scotoma with split fixation. So this is a clear indication of going for a combined surgery, that is a phacotrabeculectomy. And this is a very advanced glaucoma. Just temporal island of vision is left. So this patient is a right candidate for a sequential approach, where first you do the trabeculectomy and then followed by the glaucoma, followed by the cataract surgery. The reason is that when you do the glaucoma surgery alone, you get a better IOP control as compared to doing the sequential approach. Okay, so on what basis would you take the surgical decision that what procedure you have to adopt? So first is the amount of cataract. If my patient has a very minimal cataract and an advanced glaucoma, then obviously the decision would go in favor of doing the trabeculectomy. And I'm not able to control the intraocular pressure to the target level. And if the damaging IOP is very high, say for example, it's 35, 40 millimeter of mercury when patient comes to me, I know for sure that I won't be able to control the intraocular pressure just by doing the combined procedure. So probably I may take a decision to do the sequential procedure and the target pressure. Say for example, the normal tension glaucoma, where target pressure sometimes even goes in single digit, and where definitely I would like to do the combined approach, or maybe a sequential approach, first the trabeculectomy and then followed by the cataract surgery. The stage of glaucoma. As I said earlier, the mild glaucoma and ocular hypertension, yes, they require a very simple cataract surgery alone. And if the patient has a moderate to advanced glaucoma, then they require a combined procedure, that is a trabeculectomy. And then if the patient has an advanced glaucoma, then that patient requires first a trabeculectomy if the cataract is mild, and then followed by the cataract surgery. You can see over here, there is a small splinter defect with a disc hemorrhage. So obviously for this patient, I would just do the cataract surgery alone, because I know that for sure that if the patient remains in the 20, 22, 24, then also this patient would not progress substantially over a period of time. And this is a moderate glaucoma, there I would definitely adopt a combined procedure. But if this kind of a patient is there with me with hardly a barely minimal cataract, then I will do the trabeculectomy first, followed by the glaucoma, followed by the cataract surgery. The other factor which influence is the patient age. If the patient is an elderly patient, then there is no point in doing the combined procedure. Just do the cataract surgery and explain to the patient that he may require one drop probably post-operatively, because the longevity of the patient may not be very high. And coexisting ocular comorbidity. Like this patient, you are seeing that this patient has a pseudo-exfoliation, and this patient has a pigmentary dispersion syndrome. So these are the patients who are very fast progressor. So if the and many of them are very young patients. So if these kind of patient comes to you with a very high intraocular pressure, with this kind of ocular comorbidity, then definitely you have to prefer to do a combined surgery rather than just doing the cataract surgery, in spite of the less glaucomatous defect. And the coexisting systemic morbidity, that always you have to consider in your mind that suppose if you have to do a two surgery, sequential approach, and patient has a significant systemic comorbidity, then that patient probably may not withstand to sequential surgery. So better it is to do the combined procedure. And you have to look into the socio-economic status of the patient also. If the patient is coming from the rural area, and you know for the sure that the family member would not take good care of the patient, so obviously all of us knows that the patient glaucoma is a lifetime disease. Patient has to come to you for a lifetime follow-up. But still, by doing a combined procedure, you can do a good years of a quality vision to this patient, if even patient lost for the follow-up because of the socio-economic reasons. So these are the conditions where you may have to alter or change your decision, or these may influence your decision what procedure you have to adopt. And where you would do the cataract surgery alone. So first indication where I would do the cataract surgery alone is the primary open angle glaucoma with mild to moderate damage, because I would let you know that by doing just a cataract surgery, you would be able to reduce the intraocular pressure in some patients very significantly. Ocular hypertension, all ocular hypertensive patients, they need just a cataract surgery alone. There is no need to do a combined procedure. Normal tension glaucoma, you know for sure that their target pressure might be pretty low, but another reason for this is that normotensive glaucoma patient, they are the slow progressor. They don't progress fast, so you don't have to bother about that. You just explain to the patient about their condition, do the cataract surgery alone, and whenever the need arises, put the patient on an anti-glaucoma medication, patient would do good. And all angle closure diseases, you know, this is the spectrum of the condition which is very common in our country. Almost 30 to 40% of the patients, they have an angle closure disease. And many of these patients, if they have not landed in a chronic angle closure disease, then they would do good just by doing the cataract extraction. Lens-induced glaucoma. Most of these lens-induced glaucoma patients, they just require a cataract surgery alone, because these are the patients who are symptomatic because of the high intraocular pressure, and the high intraocular pressure is not of a very long duration. So in these patients, you just have to do the cataract surgery, whether it's a phakomorphic glaucoma or a phacolytic glaucoma or a phacotopic glaucoma. You just do a cataract surgery alone, and subsequent to the cataract surgery, assess the glaucoma properly, and if required, treat the glaucoma as per the requirement, either medically or by doing the sequential approach, that is the second surgery by doing the trabeculectomy. If you have decided to do the phacoemulsification only for this patient, then always do a temporal phaco, so that you can preserve the superior conjunctiva, and by preserving the superior conjunctiva, your subsequent glaucoma surgery, if needed, becomes pretty easy, because that conjunctiva is as good as the virgin conjunctiva, and the chances for the success of the surgery becomes pretty high. So that is a subgroup of a patient which is pretty common in Indian population. Almost 30 to 40% of our patients who have a primary glaucoma have a angle closure disease. And the angle closure disease basically is a morphological condition where the axial length of the eye is less, where the depth of the anterior chamber is less, where there is an anterior chamber lens vaulting. So all these factors contribute for the oppositional closure of the angle, and the primary treatment, if they don't have the cataract, is just do the peripheral iridotomy, and this peripheral iridotomy open up the angle recess and the aqueous flow establishes and the pressure goes down. But if they have a significant cataract, or if the lens is a significant factor for causing the angle closure disease, then it is better to take out the cataract. And if you take out the cataract, then you see that, this and AC depth has increased significantly, and see the angle recess is open significantly. And if your peripheral anterior synecdoche has not caused any irreversible defect to the trabecular meshwork, then these are the patients who would do good just by doing the lens extraction. I would never ever recommend to go for the clear lens extraction, but if even the patient has a early cataract, and if the lens thickness is very high, it's almost more than 3.5 millimeter, maybe 4 millimeter, and very shallow AC, then these patients make good choice for doing the clear lens extraction. And these are the group who would do just good by doing a clear lens extraction. So just by doing the clear lens extraction, you increases the depth of the entry chamber, and you wide open the angle recess, and you give a free access to the aqueous humor, and that's why the pressure remains normal for a very, very long time, and these patients, they never require any medication. So this is one of the example. You can see that, this patient has a very, very shallow anterior chamber and very significant, visually significant cataract, and the pressure was very high, 40 millimeter of mercury, and we tried to do the YAG iridotomy, which was patent, but still the pressure was very high. So after controlling the pressure with the mannitol, with mannitol and the systemic carbonic anhydrase inhibitor, we decided to take the patient for the surgery. And for this patient, we found that the lens was slightly subluxated anteriorly. So probably the patient might have had some trauma in the early part of his life, and that might have aggravated. And because of the weak zonule, the lens might have moved forward, and that might be a cause of a very high intraocular pressure. So that we realized while we were doing the capsular access. So after dilating the pupil very well, with the iris hook, you can use any of the method to expand the pupil. The CTR was put, and then the patient underwent the uneventful cataract surgery. And believe me, this patient still has a very, very normal intraocular pressure and very healthy disc. And the decision taken for not doing the combined procedure was totally based on the optic nerve head changes. The optic disc of this patient was poorly visualized, but that was very, very healthy. So we just did the cataract surgery alone, and this patient, obviously you can see that this temporal approach was done, and this patient did very well after the cataract surgery. And I have done several year follow-up of this patient, and still that patient is doing pretty good. So these are the patient where you have to take a decision based on the patient's condition. So in angle closure disease, the various procedures are recommended, right from the clear lens extraction to the trabeculectomy to the combined procedure, and every procedure was head-on compared with the classical trabeculectomy, and also with other competitor procedure like phacoemulsification were compared with the trabeculectomy. The clear lens extraction only was assessed, and the phacoemulsification was compared with the phacotrabeculectomy in all chronic angle closure glaucoma or various form of angle closure disease. And this is all study. Most of these study were done by the Tham and his colleagues, and they found that in most of these patients, you can achieve the target intraocular pressure, but decision whether the patient require trabeculectomy alone or a lens extraction or a combined procedure is totally a clinical decision based on the condition, based on whatsoever I have narrated earlier, that how much is the glaucomatous defect, how much is the amount of the cataract, and obviously you can achieve the target intraocular pressure in most of the patients. Now, talk about the intraocular pressure changes after the phacoemulsification. Yes, every single uh, cataract surgery causes drop in the intraocular pressure, but drop is more uh, if the patient has an angle closer disease and ocular hypertension study. The ad hoc follow-up of the ocular hypertension disease, uh, they have shown that the intraocular pressure drop up to 6 to 8 millimeter of mercury from the baseline. That is very, very significant. And that is true even for the angle closer disease, that even many of the patients show the drop in the intraocular pressure up to 30 to 40% from the baseline. And even in the POAG, where the trabecular meshwork is compromised, but still, if you do a cataract surgery alone, there is a widening or deepening of the entry chamber and widening of the trabecular spaces, and that leads to drop in the intraocular pressure by around 2 to 4 millimeter of mercury. So, patient who has a primary open angle glaucoma and just a mild glaucomatous defect and a cataract, you just do a cataract surgery alone, and the patient would do good. So after routine phaco, you can expect a drop of the IOP around 2 to 3 millimeter of mercury, even in the healthy subject. Even in the healthy subject, that is just because of the change in the morphology of the trabecular meshwork and the entry chamber angle and the entry chamber depth. Now come to the sequential approach, where you would do first the trabeculectomy and followed by cataract extraction, because the reverse sequential approach is not seldomly performed approach. And this is a traditionally approach for advanced glaucomatous defect. If I have a patient who has a mild to moderate are not very significantly advanced cataract and but very advanced glaucoma, then my choice would be to do the glaucoma surgery first, so that you can get a very good bleb, and this bleb would survive for very, very long time. So do the superior trabeculectomy, and whenever the cataract progresses or becomes more visually significant, then do the temporal approach and do a good cataract surgery, and your bleb survival will be enhanced as compared to the combined approach, that is the phacotrabeculectomy, where you would do the sequential approach. For me, one of the indication is the iridocorneal endothelial syndrome. In these patients, you can, if you do the trabeculectomy along with the cataract extraction, the trabeculectomy 100% would fail because this trabecular membrane would grow and it would block the deeper ostium, and the trabeculectomy would not survive. So this is one of the group of the patient where either I would put the AGV or I would put this mini shunt in this patient. And these patients, though they are very difficult, their cornea is also compromised, but most of the time they do good for a few to several years. And where you would do a sequential surgery, where the diagnosis of the glaucoma is in doubt, and the lens-induced glaucoma. So these are the conditions where you would prefer to do the reverse sequential surgery, like chronic angle closer glaucoma. You would probably may do where cataract is very advanced, and you may like to take a chance whether this patient do good by just doing the cataract surgery, and if the patient do not do good, then you may have to do the trabeculectomy at later date. Similarly, in lens-induced glaucoma, rarely these lens-induced glaucoma, particularly the phacomorphic glaucoma one, they developed irreversible damage to the trabecular meshwork, and you have to do the trabeculectomy to control the intraocular pressure at a later date. So these are the conditions where you have to do the reverse sequential approach. So the combined surgery, that is the phacotrabeculectomy, is the second most commonly performed surgery across the globe, not only in my practice, but across the globe. And where you would do this combined surgery, where there is a coexisting glaucoma and the cataract, and the glaucoma is progressing in spite of the medical treatment, or if the patient is not tolerating the medical therapy and the glaucoma is progressing, or maybe because of some socio-economic status, or if the patient has a moderate to advanced glaucoma, these are the patients who require a combined cataract and glaucoma surgery together. There are definite advantages of doing the combined surgery, that it eliminates the risk of future surgery another future surgery. So morbidity reduces and it prevents the early post-operative IOP spike. Many of these patients, even following the phacoemulsification, you see the IOP spike, and sometimes this IOP spike might be hazardous or deleterious to the optic nerve head if it is already compromised. And there is a faster visual rehabilitation, particularly in one eye patient, because they cannot see. If you do the patient has advanced cataract and you just do a trabeculectomy, then again they have to wait for another 3 months to go for the cataract surgery. So for faster visual rehabilitation, sometimes you have to do the combined cataract surgery, even you may not desire to do so otherwise. And obviously in some patients, it may be because of the comfort and the economy. And obviously, if you are doing the combined surgery, then it reduces the morbidity because you are not doing the two different surgeries. If you have decided to do the combined surgery, the option is the trep phaco, which is very commonly performed the combined procedure. And in my practice, it's almost 100% trabeculectomy and phacoemulsification together, because I'm not well versed with the MIGS and phaco, but it is getting momentum in the Western world. And now with the micropulse ciliary ablation, some people have started doing phaco plus ciliary ablation, but I do not recommend, because after all, it's a destructive procedure and it does cause lots of inflammation, particularly in the anterior vitreous space, which is not good for the patient because it may cause CME, development of CME as well. So phacotrabeculectomy, I will show in the next slide because I know that I'm running out of time. This is a small pupil and up to the 4 millimeter of pupil, because many of these glaucomatous patients, they are pretty challenging and they have a small pupil, and a combined procedure has to be done by those people who are well versed with that, because it is more difficult as compared to doing the phaco emulsification alone. And many of these patients, they have a subluxated lens, they have a pseudo exfoliation, they have a very rigid pupil, because many of these patients are on the pilocarpine for very long term. And if I have a patient having a pupil up to 4.5 millimeter, I'm able to comfortably do a combined procedure without dilating the pupil. So I always make a fornic-based conjunctival flap. After making the fornic-based conjunctival flap, I resist a triangular partial thickness scleral flap, and then I demarcate the deeper block, which is approximately 2 into 1 millimeter. And then after that, I do the routine phacoemulsification. And after the phacoemulsification, I will put the intraocular lens. And after putting the intraocular lens, I will do the deeper block dissection. And many of my colleagues, they recommend that if the patient has a open angle glaucoma, then there is no need to do the iridotomy. But I would always do the peripheral iridotomy because it prevents the pupillary block in the early postoperative period. And either I will apply just a single apical suture, or if I'm putting a 3 suture, then one will be a releasable suture so that I can release it afterward if I have to control the intraocular pressure. So this is a similar kind of a patient, and where I just put the iris hook. So I don't want to waste your time. So what is the post-operative management in my patient? Routinely, I give a topical steroid to all my patients in a tapering doses, last up to 1 month, and then antibiotic drop is given for a week, 4 times a day. I don't use cycloplegic because cycloplegic sometimes become very notorious and causes a posterior synechiae and pupil always become dilated. So the cycloplegics are reserved only for those patients who have a hypotony or who have a shallow anterior chamber. Then only I would use cycloplegic, or sometimes I would use a cycloplegic in an angle closer glaucoma where I was not able to control the intraocular pressure following the YAC PI. I would put the releasable suture. If I'm not able to put the releasable suture, then I would prefer to do the sutural to control or to titrate the intraocular pressure early post-operative. Just one word about the premium IOL. I don't use the toric IOL or a multifocal IOL if I'm doing a phacotrabeculectomy, for a simple reason is that the bleb formation would alter the astigmatism, and if the patient astigmatism would change subsequent to the surgery, then obviously the patient would require glasses and he would be unhappy. Similarly, the multifocal, if you have used the multifocal IOL or trifocal IOL, then also patient will have to use the glasses. And the multifocal and trifocal IOLs are notorious to affect the perimetry. Also, the mean deviation go down by around 2 decibel if you have used the multifocal IOL. So I would not prefer to use the toric or the multifocal IOL in my practice, but I know that many of my colleagues are using. And if you talk of the complications, there are many complications. They are basically divided into early and late complication. And most commonly seen complications are the increased IOP in the early period. Then you have to do the sutural lysis, flap massage. In the late period, then you have to put the patient again on the medication, and sometimes you have to do another trabeculectomy or a HUV. Hypotony is again very common, and hypotony usually controlled over a period of time. But if it causes risk for the development of hypertonous maculopathy, then you have to intervene and you have to do the resuturing of your flap, because most of the time the flap sutures are too. Hyphema is pretty common when you do the peripheral hydrotomy, because you tend to injure the ciliary processes, and they are very, very notorious for causing this bleeding. And if there is a significant hyphema, then sometimes you may have to drain it, and sometimes it may cause the hemorrhagic choroidal or sometimes occlusive choroidal. And if they are not able to resolve by the medical means, then occasionally, very rarely, you may have to drain it surgically. Inflammation and not very common nowadays, and the phlebitis is not very common, particularly with a combined procedure. So with the trabeculectomy, particularly in myopic patients, pretty common, but in combined procedure, because the morphology of the flap is not that great. That is about a single word about the MITS and the phaco. The people have in the Western world have started putting the eye stent that is put in the angle recess over the trabecular meshwork. It drains the aqueous in a more physiological way, and single eye stent is capable of reducing the intraocular pressure by around 15% from the baseline. And many a time you have to put the multiple eye stent. These are very expensive. If I put one single eye stent, then it would cost somewhere around 100,000 rupees to a patient. And if you're putting 3 eye stents, then the cost of the surgery may go up to 200,000 rupees, which would be very expensive, and patient may not get desirable results. And we are very, very familiar with the phacotrabeculectomy. So I would always recommend that do a procedure where you are more familiar, rather than entering into these kind of adventurous things where you are not very familiar. This is an eye stent angle recess. So obviously it works very well in their hand, and probably in future it might work in our hand as well. But still, as a student, you should wait. And as a teacher person also, I am not doing it. I might be doing it. So in summary, the phacoemulsification alone gives a modest IOP control in most of the patients, and this procedure should be adopted in all ocular hypertensive and most of the angle diseases and early POAG and with mild glaucoma. Phacotrabeculectomy seems to be more safe and fast for visual rehabilitation and acceptable for long-term IOP control. Success can be enhanced like MIGS with phacoemulsification getting popular in the Western world, but not here. Thank you very much. Thank you, Satyajit, and thank you, Maneesh.
Thank you, sir. Thank you, Dr. Vyas, for such a comprehensive. I think there is some audio. Sir, am I audible to you, sir?
Yes, yes, very much. Wow.
Yeah, thank you, sir. So, thank you so much for such a comprehensive presentation. There is some, Mr. Gupta, I think there is some noise coming.
Should I mute all, sir? If you say
You can mute all, then I'll unmute myself.
okay. Vyas, sir, please unmute your mic after some time.
Yeah. My mic is unmuted. Yeah.
So, sir has covered all the key points related to management of coexisting cataract and glaucoma. There are 2-3 questions, but I think all of them have already been answered, but I still request sir to answer them. One is, if you can please explain the reverse sequential approach in management of cataract and glaucoma.
Okay. So the reverse sequential, commonly we call a sequential approach when we do the trabeculectomy first, and then cataract surgery. The reverse sequential approach is there when we do the first cataract surgery, and then if required, we do the glaucoma surgery.
So the audio is not clear, sir.
Is it during the lecture here?
I think there is slight lag, I think. So maybe we can switch off the video, then audio will become clear, I think.
Yeah, that's a good idea. Am I audible now?
Yeah, very clear, sir. Very clear, sir.
Very clear. Okay,
Yes.
so the reverse sequential approach is that when you do the cataract surgery first and you assess the patient in the early post-operative period and you find that the glaucoma is very advanced, then immediately you have to put the patient on anti-glaucoma drug. And if you are not able to control the IOP with the medical management, then you have to do the trabeculectomy. And this usually done when the cataract is very advanced and you are not able to assess the glaucomatous damage caused in that particular patient. And this happens particularly in those patients who have a very advanced cataract or a phakomorphic or a phacolytic glaucoma, where you just do the cataract surgery alone, and maybe the chronic angle closure glaucoma with advanced cataract, and you are not able to assess the glaucomatous defect. You have to do glaucoma surgery subsequently. Rarely, you may have to do the glaucoma surgery subsequently in a situation like pseudo-exfoliation and the pigmentary dispersion syndrome, and in particular the eyes, the iridocorneal endothelial syndrome, where you may like to do the cataract surgery first and then put the AGV or the microshunt procedure. So these are the situations where you would do the cataract surgery first and then the trabeculectomy, that is called the reverse sequential approach.
Thank you, sir. I think it must be very nicely cleared the doubts. So there's one more question related to, you made a point that in cases with very advanced cataract, sometimes it's difficult to understand the disc. We have seen patients with phacomorphic glaucoma or phacolytic glaucoma where the cataract is so advanced that you can't assess the disc, and patient has come maybe after 15 or 20 days. In these cases, sir, if you like to share some practical tips, how to understand whether to go for only cataract surgery or a cataract surgery with a glaucoma surgery?
See, if the phacomorphic glaucoma is of a longer duration, then
Yes.
many people, they adopt the process of doing a combined procedure, cataract plus glaucoma together. In my practice, I would not do, because I know that in all lens-induced glaucoma, the eye is pretty thin, and pre-operatively, you don't have a much breathing space. Wait, sir, surgery, and in the same time, and even after controlling that in a short duration, you are doing the procedure, then also there is excessive fibroblastic and your trabeculectomy phase. So it is always better, in my opinion, the cataract surgery
Audio
alone.
is breaking slightly.
All
Sorry to
Uh,
थोड़ा audio break कर दिया.
Am I
हाँ.
am I audible?
हाँ, audible, sir. Yeah, audible, sir.
Audible?
हाँ, audible, sir.
Okay. So if the patient has a lens-induced glaucoma, then I would never ever do the combined procedure, for the simple reason is that these eyes are inflamed eye and there is a very high chance of failure of the trabeculectomy. So do the cataract surgery alone, assess the glaucoma, if required, treat it medically, as long as you don't do another surgery. By the time eye also will become quiet, and once the eye is quiet, you are not able to control the intraocular pressure by medical means, then do the trabeculectomy or any other anti-glaucoma procedure, whichever is indicated in that particular patient.
Yes, sir. Thank you, sir. So
Why is another clear, Maneesh?
Yeah, very clear, sir. Very clear. Sir, another question is how would the removal of cataractous lens help in improving IOP in open angle glaucoma patients? Angle closure glaucoma, we all know. In open angle glaucoma, sometimes 2 to 3 millimeter reduction is there. So what could be the possible mechanism, sir?
See, most of the patients we see in our practice that even If they don't have the glaucoma and you just do the phacoemulsification, then the pressure go down by 1 to 3 millimeter of mercury, and it remains so for several years. And varieties of mechanism were suggested for this. The most commonly accepted mechanism is that the deepening of the entry chamber and opening or cleaning up of the trabecular meshwork. Okay, because the fluid goes with the jet speed inside the entry chamber while you are doing the phacoemulsification, and there is lots of phaco energy is delivered. So the trabecular meshwork becomes clean, maybe by phagocytic procedure, phagocytic mechanism, or maybe because of the fluidics, active fluidics of the fluid flow in the entry chamber. The another mechanism which is suggested by some of the author, but not acceptable by everyone, is that in some of the patient we causes a small cyclodialysis cleft while we are doing the phacoemulsification, and some of the authors they have described it by doing the UBM, that a small cyclodialysis cleft while we are doing the clear cornea phacoemulsification is created, and that is responsible for reduction in the IOP by around 1 to 2 millimeter of mercury in many of these patients. So these are a few mechanisms which are acceptable, but I don't understand the mechanism of this cyclodialysis cleft. So I don't advocate, and I don't recommend, and I don't teach also. But the
Thank you, sir.
understand.
Yeah, I think, thank you, sir. Sir, there's one last question. If the sclera is thin with the patient having both cataract and glaucoma, then how you approach these patients for surgery?
Okay. If the sclera is very thin, then the best approach, never ever venture into the combined procedure, because this heroic approach would lead to a perforation of the sclera and you will be in trouble. So the best approach is that you put the AGV and put the scleral graft over that. That would work very well, and that is what I do in my practice.
You do AGV with a scleral patch graft above the tube?
Would do a combined cataract plus AGV together. It is very, very I do. But I will do the sequential approach, that is typical of reverse sequential. I will remove the cataract, and probably in the early post-operative period, maybe 2 months, 3 months later, I will AGV in these patients. But because the sclera is thin, or if there is an enterostaphyloma where I want to make a scleral flap, but if I get a good sclera somewhere, if the scleroconjunctivitis or those kind of condition has not caused a 360-degree scleral thinning, and if I can get a good sclera somewhere, then I may do the trabeculectomy elsewhere. And it may be along with the cataract surgery as well. But it is not very common that you get a thick sclera.
Yes, I think that is all we had, sir. But thank you so much for such a simplified presentation. You shared all the common. So you can switch on your video. I think we'll just conclude. Or Satyajit Sinha, sir?
Yeah.
Yeah. Prateep, sir, we'd like to see you. So thank you so much, sir. All the possible combinations of cataract and glaucoma you have shared. Even you discuss about the clear lens extraction. So I think there is one last question about pseudophakic glaucoma. The question is, there's no. Will you like to touch anything about, sir? What is pseudophakic glaucoma, and anything specific will you like to add about it?
Pseudophakic glaucoma. Usually, when the patient has a pseudophakia and a glaucoma, develop the glaucoma subsequently, then you treat the patient as you treat your other glaucoma patient. If there is, I'm presuming that it's a primary glaucoma. I'm not presuming that it's a secondary glaucoma, because once it's a secondary glaucoma, altogether different, and the different type of secondary glaucoma will have a different type of management. So I presume that the pseudophakia with primary glaucoma, and maybe this primary glaucoma might be an angle glaucoma. So the medical management is first. If you are not able to control the intraocular pressure, by your medical means, then do the trabeculectomy. If you have a fine, fantastic virgin conjunctiva superiorly, then do the superior trabeculectomy. If the ECC with IOL was done and if the conjunctiva is scarred, or if any other surgery is done and the conjunctiva is scarred, then yes, you have a bit difficulty. Then find a good, freely mobile conjunctiva and do the trabeculectomy at that place. And if pseudophakic glaucoma is a secondary glaucoma, then many a time we have to do the AGV as well. Because most of the time in my practice, these are the patients who have a uveitic glaucoma or a glaucoma second following the VR surgery. So these are the patients, they don't do well. I just
Thank you, sir. So I think this is all the questions we had, sir. Dr. Satyajit, so you can. Thank you, sir. Dr. Prateep, Vyas, sir, you can please switch on your camera if it is possible.
okay.
I think we have covered the topic. And Dr. Barun Naik, sir, couldn't connect, so maybe we'll have sir's presentation sometime later. Yeah.
Oh,
Dr. Satyajit Sinha, sir.
he's not there.
It must be there.
Yeah.
Dr. Satyajit Sinha.
I think, sir, he is just left, possibly logged out.
So I'll take this opportunity to thank Dr. Prateep Vyas, sir, and Dr. Barun Naik. We'll have Dr. Barun Naik's presentation on a later date, but we really had a great time listening to Dr. Prateep Vyas, sir. Very, very lucid and very important topic for exam and for practical life. How to manage coexisting cataract and glaucoma. In fact, this is something which we are doing every day in our glaucoma OPD. Patients are coming with cataract and glaucoma because the disease are of the same age group. And every patient you have to decide whether to do cataract or a glaucoma or a combined. So Saraf shared some very important tips. Just a small announcement that tomorrow Dr. Sashmita Kaushik will be discussing about congenital glaucoma and Dr. S.S. Pandav will be presenting about glaucoma shunts. So we'll request you all to join again tomorrow at 5 p.m. And I'll again thank you, Dr. Prateep Vyas, sir, for sparing your time, and it's really a blessing for the PGs to have you and get a chance to interact with you. Thank you so much, sir.
Thank you very much. And I wish all the best to all PGs. Do best in your examination and come out with a flying color. The best.
Thank you.
Thank you, sir.
Bye, sir.